All right, good afternoon, everyone. We're so happy that you all are joining us today, and we want to welcome you to Southeast Addiction Transfer Network and the Substance Use Prevention and Treatment Division of the NCPC, our National Center for Primary Care at Morehouse School of Medicine, would like to welcome you to our webinar series. We are so excited about this series. We have some great speakers lined up and some really great information as well. And the series is Women Are Different, Culturally Encouraging, Empowering, and Engaging Women in Treatment and Recovery. In compliance with ACCME guidelines, the following speakers have no financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. The 2017 to 2022 ATTC network is comprised of one network coordinating office, 10 domestic regional centers, and 6 international HIV centers. Established in 1993 by SAMHSA, the domestic ATTCs accelerate the adoption and implementation of evidence-based and promising addiction treatment and recovery-oriented practices and services, heighten the awareness, knowledge, and skills of the workforce that addresses the needs of people with substance use and/or behavioral health disorders, and foster regional and national alliances among culturally diverse practitioners, researchers, policymakers, funders, and the recovery community.
Thank you. It is wonderful to be here with everyone today, and I want to just start by thanking the Southeast ATTC, especially Don and Pamela and Sharinda for organizing and putting on this webinar. The slide that you see right here is about the overall webinar series. So this is the first of 6 webinars that will be taking place in 6 consecutive weeks. So be sure to join next week and the following week and the following week. And the way they've put together this series is really to take a look at the overall interest and needs of women and then look at some specific cultural groups. So I know the session next week is focused specifically on African American women, and then sequentially after that. Today's session is really focusing on the history of women and substance use disorders, or the kind of overall framework around what do we know around women. And the way that I'd like to do this, because this is the kind of topic where I could spend a week talking about it. It's something I care a lot about, know a lot about it, and picking and choosing what pieces to talk about. If there's something that you hear that's of particular interest or that you would like more of, then please go ahead and put a note in the chat. And so that we can come back to it also during the question time, or if I actually see the note, I may just be able to answer it and bring up that part during that particular section. So I know that in the announcement it included my bio sketch. I have been now working around women, families, youth, and substance use disorders for close to 3 decades. I know I started when I was 12. I'm also a woman in long-term recovery, so you'll hear both my work and my experience as a woman in long-term recovery, and my knowledge working directly with, literally hundreds of women's service programs and co-ed programs and systems that we're looking to improve services specifically for women kind of across this. I know that there was a disclaimer that emphasized that the opinions that are contained in this presentation are my opinions, and actually part of the content that I'm going to give towards the end is really new information or thoughts or observations of what I'm seeing in the field. So I'm looking forward to speaking with you today. The way I have the agenda structured is really, again, because this is the kickoff for the Women Are Different series, is to talk a little bit about sex and gender differences, the public health approach, which also talks about the community, and we can't really talk about substance use disorders without talking about our communities and our community dynamics, and then talk a little bit about gender responsive services, some of the trends towards gender mainstreaming or gender neutral approaches that we see, and kind of a special focus around the serving women in co-ed programs, and then some suggestions around moving forward. So that's the agenda that we have scheduled for today. So just starting with sex and gender differences. Just to, when we talk about women's specific services, and sometimes we say gender for short, but usually we're talking about sex and gender differences. So those sex differences are actual physiological differences between male bodies and female bodies. And they include things like strength, hormones, size, our reproductive organs. And particularly when we start thinking about and paying much more attention to medications, sex differences become particularly important. It's important for us to be aware of and have research on different pieces of how medications are going to affect women as well as how they're going to affect men, and make sure that that's included in studies. Gender is, and then there are some other differences that happen as well, like the telescoping effect that women experience is really a result of sex differences because of the different hormones and enzymes that we have in our stomachs. Gender differences is where I think most of the heart of how and why of women being different is in our service delivery system. So if we define gender as part of a person's self-representation, it relates to culturally defined characteristics of masculinity and femininity. And then a lot of different things come into our gender identities. So our culture, our age, our socioeconomic status, religion, disability, race, ethnicity, sexual orientation, they can all influence how we view gender, our gender roles, and our expectations. So we'll talk a little bit more about that as it fits with looking at how women are different and how we really meet women with substance use disorders needs. So there are both sex and gender differences that relate to substance use disorders, treatment, and recovery for men and women that we'll be talking about today. This particular slide has a bell curve, and I want to spend a little bit of time talking about what this bell curve is, because I find that it's a useful way of looking particularly at sex and at differences between men and women, but it also carries over into a lot of different things as well. So if you imagine a men's bell curve and a women's bell curve like they are there, and you see I talk with my hands, we know that, just using strength as an example, men tend to be stronger than women. So if over at the left-hand side you have kind of the strongest of the strong, and then most men are kind of in between at the top, in that kind of top area of the bell curve, and then it goes down, and some men have no strength. Women also have, some women have no strength at all, but some women are quite strong. So you'll see in here there's a lot of overlap in between the two, right? So if you're designing something that you want everybody to be able to use, you need to pay attention to those people who have the least strength and how you're going to be able to have it available and accessible to the people with the least strength. And you may or may not be able to come all the way over here. But if something is designed just for men, then probably it's going to be designed over here, like at that intersection, where most men will be able to use it, but really very few women will be able to use it. So, and that's true for other things too. When we think about women are more likely to have responsibility for children than men, but some men have a lot of responsibility for children. So if we want to design something to make sure that it's accessible for people with children, we don't want to go all the way over into the women's area, because that's going to exclude the men. But we also don't want to, we want to make sure that we're paying attention to these trends. What has tended to happen in our substance use disorder services, when they were first created, they were really created on this men's bell curve, which meant that some women could still access and use those services, but they often were having to adapt. And for many women, those women who don't have any overlap, they tended to not, it didn't work, they didn't relate, it didn't make the connection, and they would fall out of the services. So when we are thinking about the different kinds of programs and approaches that we want to use, I really like to think in terms of these bell curves and making sure that we're making things accessible to as many people as possible. I also want to just give a couple of disclaimers. while I'm speaking about men have a tendency this way and women have a tendency that way, it's really that some characteristics are more common among women, and some are moving, uh, and some are moving slow. I'm just seeing a chat that somebody has managed to get all the way to the end of the slide deck. I'm not sure how. Hopefully that's not true for everyone, and you're at this particular slide with the bell curves. So when we're talking in these generalizations, I just want to recognize and acknowledge that we know that there's tremendous diversity between women and men, and that women and men are not, we're really more alike than we are different. So it isn't to say that, men are from Mars and women are from Venus. There's a lot of commonality. And I also just want to give the caveat to remember that we recognize also that there's tremendous diversity among women, and that this is not all universally the same. But it is still a kind of helpful paradigm to think about some of those commonalities among women. So that's one of the first pieces, is paying attention to those aspects. Then the next piece I want to talk about just briefly is the public health model, because I think the public health model really offers a firm foundation for how we look at substance use disorders, as well as not just in terms of the medical aspects of a substance use disorder, but the more comprehensive aspects of substance use disorders and prevention and treatment and other problems that we have in our community. And then also ultimately how we go about approaching recovery and supports and wellness for people. So the way the public health model works is it takes three things to have a public health problem. Tuberculosis is the most common example that is used, and to have a tuberculosis problem, you have to have an agent, which is the tuberculosis bug. You have to have a host, and that host is somebody who is susceptible to tuberculosis. If you have somebody who is immune to tuberculosis and they meet a tuberculosis bug in a park, you won't have a tuberculosis problem. But you have some people who are susceptible to tuberculosis, and so when they run into a tuberculosis bug in an environment which encourages the development of a problem, then you end up with the tuberculosis epidemic. So the same model really can apply over to our substance use disorders. It also applies to our opioid crisis, to alcohol problems, where in order for us to have a substance use problem, it takes three different things. It takes agents, it takes the alcohol, the tobacco, the medications, the illicit drugs. If you can remove all of them completely, then you will not have substance use problems. So, and that's one of the strategies around interdiction, and some universal prevention strategies also work on reducing accessibility of agents. It takes hosts, individuals who are susceptible to developing an SUD problem. And oftentimes those individuals, I say, are surrounded by families, because we don't live in isolation. So when we're thinking about the development of SUD problems, it isn't just the individual, but also their families, which can be really very profoundly impacted. And again, those problems are not just substance use disorders. So driving under the influence is a prime example of a substance use problem for a community. It puts a lot of people at risk. And solving that problem and then going home, there's also a lot of accidents that can arise as a result of substance use, accidental overdose, as well as other risky kind of behaviors and injuries. And they have to interact in an environment. So again, individuals who are vulnerable to substance use disorders, who are in an environment which does not condone or have access to a lot of substances, usually are able to do pretty well, and are oftentimes do not develop full-fledged substance use disorders. But when you have individuals who are living in environments which really encourage substance use, the media may be encouraging it, there's a lot of access in their neighborhoods, their peers may be using it, and they also have those particular vulnerabilities or risk factors for developing problems, then we want to, then that's really when the problems start to evolve. So part of what we, I think, try to do when we're working on this is we want to think about all three of these and how they have a direct effect on women and women's opportunity. Treatment is a host-based strategy, but we also want to pay attention to the environments that people live in and how to build environments in which people really can be healthy and focus on wellness. So that's the public health model, which involves those environments, those communities in which we live. And so women are a key part of those communities, and then women go to different places. We have churches, we have grocery stores, we have schools, we have neighborhood groups, we have our friend groups, all interacting in those environments. And one of the things that I like to start about, and sometimes I do this as an activity, is something positive about women that we see in our lives. So if everybody wants to take a moment and go ahead and chat something that you really see about women that is often the case. And again, this is not every single woman, and it's not necessarily at an exclusion of men, but what are some of the things that you see about women that make women so amazing? We have a few people typing. Supportive, resourceful, nurturing, compassionate, caregivers, strong. Give just another moment. Pull up a few others. Putting others before themselves, empathetic, and empathic, both. Right, and fair, and generous, and resilient, and able to multitask is one of those ones that I probably am the one who first put that. Caring, so dedicated. So paying attention to some of these positive features of women. One of the common themes that I use across everything I do is that we have a tendency to think about problems and how we need to help people reduce problems. And in reality, most women are used to seeing what they don't have, and they're not used to seeing what they do bring to the table and what their strengths and assets are. So it's important to look for and recognize and acknowledge those strengths. So again, in that community model and paying attention to women and how women are different, there are also some things that are less ideal for women. So women are often highly sexualized. If you go to a car show, that's the place that I think leaves me the most jaw drop. If you look at the advertisements that we have, if we look at some of the different approaches or how we even interact in our environments, you'll see that there's a lot of sexualizing of women and how that affects particularly young women and girls, but then women as well, and some of the effects that can have as we're moving towards trying to be healthy and oriented towards recovery. Women are much more likely to be in poverty. Women are more likely to be responsible for their family members. That includes children as well as parents or aunts or uncles. So if you have a woman who, oftentimes you'll have a woman who can't come to a service at a time she's supposed to go to it because she is supposed to be the one taking her aunt to the doctor. And sometimes we have provisions for her children, but we don't have provisions for her aunt. And it's very, very difficult for many women to be able to say, I'm going to try to put me first and do this treatment and not take my aunt to her doctor's appointment. In general, that's frowned upon in her family, whereas families often are more supportive of men who are seeking treatment. And she's also carrying with her what the needs of those different family members are. Women face more stigma and shame for substance use disorders and addictions than men do. Dr. McMahon did some research, this was a few years ago, and he actually talked to men with substance use disorders about how they viewed women who also had substance use disorders. And he found that even among men, even among men in recovery, women were more stigmatized, and there was a more level of shame. And I don't know if some of that is because it runs counter to some of the role models that we have in terms of the expectations of us being good mothers, or if it's also because of some of the stereotypes that go around women's addiction and sexuality, where there's this idea that women must be somehow involving their sexuality in their addiction, whether or not that's the case. But I think that might create more of that stigma and shame. women are more vulnerable to violence, and that has a profound effect on almost every decision that women are able to make. So paying attention to where we go, how we're going to go, and then also living with that violence after they've been perpetrated. And we'll talk about trauma in a few minutes. And then women are underrepresented in business and government leadership still today. So while there's been significant progress when it comes to role models and looking at some of the leadership, it still has a tendency to be primarily men. And I will just acknowledge the great strides that we've made in the last 6 months related to increasing involvement of women. But this is part of that community paradigm when we come to look at women's substance use disorder treatment needs that we have to pay attention to, because this comes into services with women, right? And when women leave services, they also leave services to come back into these environments. So related to substance use disorders, women's pathways to substance use disorders, the risk factors, the consequences, the barriers to treatment recovery, and the recovery support needs are usually a little bit different than those for men. Again, it's those bell curves, right? There may be things that are universally needed, but there's some things that are more common among women, and there's some things that are more common among men. And I'm just going to spend a few minutes going through a few different pieces. One, because I don't like to just talk about the negative without also talking about the positive. Some of the protective factors that have been identified for reducing substance use disorders seem to have a higher impact among girls and young women than they do among boys and men, particularly like the family dinner and having that strong sense of family and high parental warmth, religious, spiritual practices that they're engaged with, and having strong coping skills are all protective factors for girls and young women. Some of the common reasons and risk factors for initiating substance use, and remember that these risk factors then become relapse factors as well if they aren't addressed. The first one is the influence of relationships. So it is not uncommon for younger women and young women, like high school age or even middle school age sometimes, to be introduced to substance use by a male partner who is older than they are, and builds part of that dynamic. And that influence of those relationships on women's substance use is very profound. Also, mothers with substance use disorders increases the likelihood of a daughter having a substance use problem. Another piece, which is more common risk factor for girls and young women than it is for boys and young men, is co-occurring disorders. So Steve Hinshaw did some research focusing on ADHD, and then there's also been a lot around particularly mood disorders, which significantly increase in sort of the 15 to 17-year-old age group among girls. And there's a high association between those co-occurring disorders and substance use, and some self-medicating perhaps of those undiagnosed co-occurring disorders. And that, again, sort of going to some of those teenage desires to fit in. Trauma history is one of the biggest predictors of substance use among girls and young women, especially untreated trauma, and we'll talk a little bit more about that later. And then the last is prescription medication. Women are much more likely to be prescribed medications than men are, and often will, because there's this tendency towards giving women medications, that makes women also more vulnerable towards those medications and towards those risk factors. Some of the other risk factors, easy access. I think I mentioned this briefly earlier, but Coralie Wetherington did she's the director of women's, and it's not called initiative, something like that, for NIDA for a long time, women's programs it may be. She actually compared research around young women's substance use to look at whether if you control for opportunity, the rates are just as high among females and males. So And what she found is there is a high correlation. So the more likely you are to have the opportunity to use substances, the more likely you are to actually use substances, which doesn't sound, it does, it sounds sort of automatic, I suppose. But part of what we want to pay attention to is as there's been significant changes in our sex and gender roles, and girls are much more active in the communities and doing much more. They're more likely to be out like playing sports at their schools. They're at, and rather than being kept closer to home, access increases, so that vulnerability increases. Having positive effects, if you have used substances and you have a negative effect, then of course you're less likely to use substances. Having a lack of positive activities is also the one of the risk factors around substance use, and these I think are risk factors for both males and females. That having something concrete to do that you believe in, where you're developing your leadership and your sense of competency. And then the home atmosphere is, of course, another piece related to that. So again, I'm providing this as kind of context for how we start to think about how women and men are different, and then I want to get us to what we do about that. So one of the things, this quote actually comes from Francine Feinberg, and I think it's really helpful for us to be aware of it, is that oftentimes the problems and consequences of substance use for women, they tend to be personal and self-destructive, ending up in vulnerable places, having health consequences, staying involved in a relationship which is destructive, passing out on the kitchen floor, being vulnerable to homelessness, finding themselves in different situations. Those there also tend to be both less visible and more shame-based. Problems and consequences of substance use for men tend to be more societal and destructive. And so, driving a vehicle or getting into trouble or having a fight, and again, they're external rather than internal, and they tend to draw attention, and they tend to also be things that go with that, especially for young men, for that sensationalizing and that thrill seeking. So even when it doesn't work out, they get that kind of reward of a thrill seek. So this also goes to some research which has been done, particularly around, I think now they're starting to do the research around initial use, but the most of the research I've seen has to do with relapse, where males are much more likely to relapse when things are going well and they're having positive effects. For women, they're much more likely to return to substance use. I'm sorry, I am trying to eliminate the word relapse from my vocabulary, but after a period of abstinence, to return to substance use as a negative, as a result of something negative, a relationship breakup, or a sense of depression, a sense of feeling of hopelessness, and that's more likely to lead to a return to substance use among women. So both in terms of the problems and consequences, and then also in terms of the paying attention to what might lead to a recurrence of substance use, being mindful that women are also often invisible in those pieces, and they can feel like a lot of shame as well. The other piece here, and it's not just self-destructive, but it's often much more hidden, is the impacts that substance use can have on children. So the other place where there's real motivation for seeking help, usually among women, and an ability to provide interventions which can be really motivating. It's a time of great motivation when things are working well. It has to do with the fear of losing your children, losing relationships with partners due to seeking treatment, reproductive consequences related to pregnancy in particular, and then the telescoping effect, which I know somebody asked about, has to do with the way women's bodies absorb alcohol makes women more vulnerable to significant health consequences as a result, and towards faster intoxication. And there's been some research also on telescoping within other substance use as well. So that's called the telescoping effect. It means that women tend to develop full-fledged substance use problems, particularly health consequences, through shorter use than men. Also being exposed to violence is another potential consequence. So these consequences ideally become points of intervention also to help women. And again, I think people have been putting questions in the chat, but I'll also just remind you to go ahead and do that. So some of the main motivators for seeking help for women, referrals often come from social services, child welfare. There are more self-referrals. Women are more likely to seek help than men are. Men are more likely to be referred and then go because of a negative consequence if they don't. Pregnancy, again, as I mentioned, is often a prime motivator. And the other piece that I've added here as one of those motivating pieces that I do think is really important is relationships. Is that when a woman goes to a program where she's seeking help and she feels like she meets somebody there who genuinely cares about her, who is engaged and interested in hearing her story and is happy to see her, that is probably one of the biggest motivators for women to keep coming back among anything. So even though these pieces are all motivators, often women feel hopeless, they have a lack of self-efficacy, and they expect to fail. So one of the things that I really believe in is that we have to instill a sense of hope, and sometimes we have to do more for women to help them to be able to start to take care of themselves and see that it's possible than is often the case for men. So how we build that self-efficacy becomes a very, very key point for women. Because if what we do is we give them an appointment at Thursday at 3 o'clock, and maybe we even give them a call reminder and they don't come, part of what happens for them is they say, oh, well, I failed. Of course I failed. I am me and I can't do anything right. If we figure out how to make sure when they get there for that appointment, or if they get there 2 hours late, that we say, we are so glad you're here, and we recognize the accomplishment part to it, then we tend to start to build their sense of success. I was able to get there. It was worth it. I can do something right. And this is also really important, particularly, one of the things that we have on here is that pregnancy and having children is a strong motivator for treatment and accessing help. That is absolutely true. But when she is pregnant and accessing help, if what the message she gets is, you're going to lose this child, you're not going to get to keep this child, it is no longer a motivation for help. Even no matter how much she cares or loves, that creates such a high level of grief that it becomes the opposite. And because the only coping skills, right, that she has for how she's going to address grief is through substance use. So making sure that we help people to have their feelings and build hope and start to build their sense of who they are and that they're worthwhile just as they are as an agency is one of those really main points that we can bring. I know that this series is called Encouraging, Empowering, and Engaging Women. So these are some of those ways that we figure out how to do that as part of the real keys. I'm just looking at the clock, so I'm going to go very fast because there's a few other things I want to make sure that I get through. So this slide just talks about the roots of the substance use disorders treatment system that we have. And we've already talked some about that. I will share with you quickly the story of the monkey and the fish. A monkey and a fish get caught up in a flood, and there's torrential storm. They're flowing down, and the monkey sees a branch. He reaches up, he grabs the branch, and then he sees his friend the fish also through the torrents, and he grabs his friend the fish in order to help the fish and pulls him out of the water. And that's really, in some ways, how our substance use disorder services started. We are women being fish and men being the monkeys in that particular case, although perhaps I should think of other animals here. I didn't create the original story. the system was really designed, and frankly, I'm not even sure how much the original systems were helpful and conducive to men, but it was designed one way, and then women were just kind of brought into that, and we had to start to learn a little bit more how to specifically meet some of the needs of women. And I'm just going to jump into talking a little bit about gender responsive services, and then I want to come back to that evolution of the services as we're looking at. So Stephanie Covington, who's been a real leader around serving women and expanding access to women in both substance use and in corrections, and also has done a lot of work around adolescents specifically as well, has a definition of gender responsive as creating an environment through site selection, staff selection, program development, content, and material that reflects an understanding of the realities of women's lives and is responsive to the issues of the clients. So that's what we want to strive for in how we go about serving women. And to build on that, we have some principles. And there's different lists of gender responsive principles. This one's come from SAMHSA's tip 51, which is treatment improvement protocol addressing the specific needs of women. So those are the ones that I've used here. I often will talk also about strength-based approaches as one of those essential principles as well. But we want to make sure when we're serving women that we address women's unique experiences, that the system isn't fully designed around the experiences of men. So, for example, women often are parents, and so if the service system is all based during the 9 to 5 kind of hours, women often do not have access to be able to attend. Paying attention to, I looked at, and sometimes when I do long sessions, we actually look at pieces of some of the different curriculums. If you look at some of the pieces around CBT and looking at employment issues, does the employment issue section reflect the needs of women? Is there a conversation around sexual harassment, for example? Because oftentimes there isn't, and when you have women in early recovery and you're helping them with employment, those are some of the key issues that they're going to need to be addressing. Our service is trauma informed, and as we know, at this point, it makes more sense to just assume that women who are coming in for help around substance use disorders do have some level of experience of trauma, and to base the services in a way which is trauma informed. It's not going to hurt anybody to be trauma informed. But it is important to remember, kind of going back to that sense of self-efficacy, that fully expecting that I'm going to fail. When you have experienced repeated traumas, then those traumas actually start defining your life and affecting your worldview, so that you lose the ability to think that you have a sense of control over what it is that you're doing and how you're going to be able to move forward. So part of when we're looking at really serving women who have experienced complex trauma, we need to be thinking about how do we help them to have some sense of control in their lives. So it's more than just using it for motivational interviewing to help them evaluate what their priorities are and how substances might be affecting them. It's really also helping them to start to discover who they are and what it is that they want moving forward, so that they can sort of almost as pre-work before you can talk about their motivation, right? So it's instilling some of that sense of hope and belief that they can have something worthwhile in their lives that then prepares them to move into some of these other pieces. Using relational approaches. So, group therapy, where you sit in a group and you talk about a particular thing, is a very common treatment approach, and it's really designed for women. Particularly, I know we have a number of people here in the mental health system. Sometimes I jokingly say the substance use disorder system was developed by men for men, and then we figured out how to use it for women. Well, the mental health system was really developed by men for women, and now we're trying to figure out how to use it for men. But sitting in a group and just talking and building those relationships is an important part for women. but sometimes for other people, you want to be thinking about what are they getting out of it? What are the tangible pieces? And making sure that you take the time to make sure that people know that they're cared about, and using those relational approaches so that they're able to meet their priorities. And sometimes I use an example of a woman. This is actually a housing program. She got money for a refrigerator because she did not have a refrigerator in her house, but she really wanted to be going to visit her grandmother who was dying. And so she didn't buy a refrigerator. She went and visited her grandmother who was dying. And the program, it terminated her from service because she didn't do what she was supposed to do. Now, I call that a shame on the program, because for her, visiting her grandmother was a higher priority and more important for her recovery than it was to buy a refrigerator. So thinking about and building on those kind of relational pieces. Comprehensive women's services. Women often have a lot more needs than just substance use disorders, paying attention to mental health, housing, home, all of those different pieces. And then provided in a healing environment is the other piece that is very important. And I'd encourage you all, as you kind of go from here, to do a walkthrough of your facility to see, where is the light? Do people walk through a group of people who are all smoking in order to come in the door? What does that feel like for them? When they get inside, is this a place that feels like home for different people who we're trying to serve? If you're serving women, is there a couple of coloring books for children? Even if you want to discourage children from being there, sometimes she's going to have a child there, right? So are there things that you can adapt to create that kind of nurturing environment? I'm not going to spend some time talking about this elements of treatment, just to know that in everything that you're doing, when it comes to treatment planning, your skill building programs, your assessment approach, medications, case management, you want to be paying attention to women's specific needs. Same is true for men, but you really want to make sure that you're addressing what those different needs are. And then the same is true for recovery support. So as we have moved more and more towards a health-based model, we often are focusing a lot on helping to address the physiological needs and some of the psychosocial needs to improve and address and reduce substance use disorder. But there is a whole lot more that's really needed for women to support themselves in staying drug and alcohol free, but also to build their new life. So moving from disconnection to connection is the way that Lynetta Albright says this. Thinking about who they are. When we talk about purpose, are we entirely focused on jobs? Which is not to say jobs are not important for women, they are, but they may define their purpose and some of those first steps really around parenting and creativity, building their sense of community and relations, having a safe home. So one of the things I was just looking at an article about is, there are more, when it comes to unsheltered homelessness, men have a tendency to be more unsheltered, but there is a huge number of what we're calling the invisible homeless, and they may not meet the HUD definition of homeless, but they're primarily women, and they may go from couch to couch to couch or friend to friend to friend without having that stable place where they can kind of nurture their wounds and get themselves grounded. And then, of course, health is a key element of those recovery supports. For women, and I know one of the questions has to do with what are some of the specific areas where we want to be helping and supporting women. Relationships and knowing that you care are one of those key points. Something that I don't think has had any research done on it, but it resonates true for me for many people, is men will keep coming back to a program if they feel like they're getting something out of it. So they have to feel respected, but they mostly have to feel like they're also going to get something out of it. For women, they're much more likely to keep coming back if they feel like you like them and they feel like you care. So building that caring aspect into what you're doing. I care about who you are as you are, not who you're going to be over there, but I see you, I'm listening to you where you are today. Peer support is also, of course, uh, a really important factor in women's recovery, and paying attention to that flexibility and scheduling, because women may need to put those family obligations, etc., before their ability to come and commit to a particular session. This last piece talks about mental health, and it gives you a definition of mental health that I think is important for us to have, because this, to me, this is actually what we're striving for. And the first time I read this definition, I actually started laughing because it sounded so not obtainable to me. A mentally healthy woman has a positive self-image and is able to manage the challenges of everyday life, such as work, family, traffic, and relationships, as well as periodic significant events. So, and I will say that today I am a reasonably healthy, mentally healthy woman, but having that ability to know who you are and that positive self-image, that takes time. It takes creativity, it takes opportunity, it takes identifying some of your strengths that are not just physical characteristics, and really being able to use those. So joining a choir might be more important than going to a group around something else, because it's rekindling that kind of sense of value. Managing the challenges of everyday life, and I just want to quickly mention, this is much easier to do when you have financial resources than when you don't. So thinking about those challenges of everyday life, when you're a single parent with limited income, is much harder to manage some of those things than otherwise. So recognizing and acknowledging that and supporting people where they are, and not having unrealistic expectations. One of those kind of key pieces I think that's really true for women is we really want to make sure that we find and have a lot of praise, and that we also have paces that are realistic. And then, being able to garnish the support that you need during those significant events. So I'm going to just close with more of a comment, I think, than spending a lot of time. As we have evolved, because I noticed that this was history as part of it, we've evolved a lot in substance use services for women. And in some ways, we're actually ahead of the domestic violence fields and some of the mental health fields, which historically have served more women, I think, out of necessity. So in the 1960s, pretty much what we had was treatment and 12-step programs, which were very oriented towards men. Sometimes women participated, but the model was very much about men. We moved into recognizing some of the gender differences, some of the psychosocial, some of the need for parenting in the 70s. We started some research. In the 1980s, gender-specific treatment was evolved. So not just recognizing those differences, but we started to have some women-specific programs. And we also started to have more research around women. And not surprisingly, those original women's programs basically took that male model and just put it in an all-women environment. So that improved the environment women were seeing, but it also it improved the environment that women were in, but some of those other aspects, like recognizing around women's needs, were still diminished. So we've moved into this gender responsive and trauma-informed services in the 90s through the 2000s. And we've developed a lot of different models. We've also developed models around family-centered approaches. There was a couple of real milestone research studies, particularly the co-occurring disorders and violence study, which resulted in a lot of research specifically on women. And now where we are in the 2010s, as I am closing, and I wanted to spend a little bit more time on this, we're trying to keep paying attention to gender responsive as the substance use disorder field has changed. And we're moving increasingly into a healthcare environment, which tends to also put us also in more of a gender mainstreaming. So I recently looked at a plan around what is it talking about related to women. And in the opioids, there was a little discussion around pregnant women. And then in terms of other pieces, it's recognizing that gender has a role in cultural competency. So increasingly, I think we're starting to see more gender mainstreaming where we have co-ed programs that are trying to do enough person-centered programs or women's-only groups for those women who really want to be accessing those pieces. And then we're also seeing gender-neutral approaches in addition and making sure that those are also addressed. One of the things that I didn't say at the very beginning, but is one of the sort of key beliefs that I use around gender responsive services is that it's important to pay attention to women's needs, whether they define themselves as a woman, as long as they're defining themselves as a woman or society is defining them as a woman. So transgender women, as they define themselves as women, have a role in gender responsive services. They are going to be more appropriate for women, for transgender women, than a non gender responsive service. So one of the things that I think we see as we move here, and why I'm so pleased to see that you're working on this Women Are Different series, is the need and desire to preserve women-specific programs and groups using a broad definition of women. I recently spoke with a colleague who has a transgender child, and the way the child speaks of this, the child just shrugs her shoulders and says, "Some girls have penises." And while that, for me, that was very, very helpful. Is just like we have those bell curves, we have some different kinds of approaches. She identifies that that's one of the areas her body is a little bit different, but all of her other elements of who she is fit as a girl. So we want to make sure that transgender women and non-binary individuals, that we have inclusive and non-discrimination approaches and gender neutral bathrooms, for example. But what we don't want to do is we don't want to lose the gender responsive, the women specific approaches while we're trying to do that. So making sure that we're addressing both at the same time is one of those real key points. Ensuring our workforce is able to address gender as well as culture, maintaining discussion, keeping safety, and there's some specific strategies around co-ed programs, and having patient choice are all some of those particular key elements. Moving forward, I just want to remind you all to continue to be mindful of women's needs and dynamics between women and men, to keep talking about sex and gender among staff, with patients, in your daily discussions with your collaborators, to really work on creating sanctuary with no tolerance for harassment or objectification. Keep learning, and don't forget to take care of yourself. So with that, I'll go ahead and close. There are a couple of other slides that you'll be able to look at when we break, and that leaves us a couple of minutes for questions. Thank you.
I don't know about you all, but that was a really informative presentation, Deb. It was some very interesting things, and we do have some time for some questions. So we're going to kick it off with some we got from registration. What are some strategies to keep African American women in treatment?
So specific. The next webinar, which is next Thursday at the same time, Dr. Harrison is going to focus specifically on African American women. A couple of different things that I'll say related to culture is that different groups have different, and again, remember these bell curves. It is not that all African American women think one way, because we know there's tremendous diversity. But there are sometimes different approaches to authority and different approaches to talking about your problems, that you want to make sure that you're creating a culturally safe and sensitive environment for the women who are coming in. That might be African American women. There's also different approaches to some of those things with other communities as well. The same issues around access and children and providing that safe kind of environment.
Okay, we're going to move on to the next question. Thank you for answering that. What changes have been made in treatment centers to help women?
One of the things, I think I talked a lot around some of the gender specific kind of approaches already, and how do you create a gender responsive environment. So within co-ed settings, there are different approaches. One is to try to figure out how to make sure that you're providing safety, that you're matching people to primary counselors who they're going to have a dialogue with, that when you're scheduling groups that you try to cluster the women together, so that if you can't have women's only groups, that maybe it's closer to 50% women and 50% men, so that you can rely more on having the women and men together. I worked with a program that actually had separate hours to create a sense of safety among women. So this was a methadone clinic, and then they had after-hour programming, and they had a lunch and women-specific kind of piece. Look at your curricula and give them a critical eye to see, is this relevant for women? Are we assuming that people have a higher level of ability to come in, more flexibility, more autonomy than they actually have? How are our peer supports handled? Do we make sure that people are trauma informed in everything that we're doing? So those would just be a few different specific examples. And I'll just say also in the resources that we kind of flew by, I'll pull that slide back up. A couple of these. One of them is addressing the needs of women and girls in co-ed settings. Actually, that picture isn't here, but you'll find it on this website, which is a SAMHSA document around specific strategies for addressing the needs of women in co-ed settings.
Awesome. And let's take one more question. What should be on a woman's treatment plan that's not on a man's treatment plan?
So that goes to the question around person-centered planning as we're moving in that direction. It isn't necessarily, I mean, obviously reproductive health may be a higher priority for women, especially if women are pregnant. I would say that what you want to be aware of in your treatment planning is what people's priorities are. And pay attention and asking questions around creative outlets, paying attention and asking questions about family responsibilities, paying questions and getting that sense. Being aware that oftentimes, while family tends to be more important even for women than it is for men, oftentimes extended family is less supportive of women as they're coming into treatment. Again, because the expectation is that women, we have a tendency to take care of other people than it is for men. So figuring out and being supportive of family-centered approaches is, I'd say, another piece. Providing comprehensive services, having trauma-specific services on the radar and coping strategies on the radar to help build access for women, I think is also very important. I also am a firm believer, this is true for men as well, that you don't ask an assessment question if you aren't prepared to help solve the problem. So, don't open up a wound if you aren't prepared to help somebody to close it. So paying attention to trauma is very important, but if you are not equipped to help address trauma, then you may want to make sure that you're not asking people about their trauma just because it's on a form or because you have a sense that you need to know. So it's really having that focus specifically for women.
Okay, great. Thank you so much, Deb, for coming in and sharing your expertise with us about this topic. Again, this is one part of an entire series, a very interesting series where we're going into different races, different groups of women and seeing how they are different. And our next session will be the same time next week with Dr. Harrison. Her focus area will be on African American women. You will be getting an email with a link to register. And also, if you look into your chat box, you will see our survey for our post-webinar survey where you can give some feedback on this webinar and what you would like to see in the future. We just put that into the chat, and we want to thank you all so much for joining us. And if you have any questions, we'll have the room open a little bit longer, or if you want some questions directly to Deb, you can find her information on the screen. You all have a great day.